tendons, impinge the muscles, impinge the nerves. So if you take a look here, notice how here our space is, well, I guess you guys aren't really familiar with it, but the space here is much narrower than normal. Right? Once you take a look at a few more pictures, you'll see that this space is much narrower than normal. But once again, right, really hard to see on X-ray. You can't actually see the soft tissue damage. So what do we use? We use ultrasound, we use MRI. Okay. So ultrasound, I'm sure there's something going on here. I have no idea what's going on here. It looks like a mess to me, so I'll leave that for one of your fellow ultrasound classmates to explain to you. But over here, this is an MRI of the shoulder. And so if you look here, the tendon should be here, tendon should be here, tendon should pass through here as well. But instead you've got this white area. That white area is fluid, so that means you've just got the joint capsule there instead. Right? So in this case, there has been a torn tendon, right? The tendon ripped, and that is our rotator cuff injury there. Shoulder dislocation. Like Ms. Hawkins said, which view is great for showing shoulder dislocations? Good, the scapular Y view. If a patient has a dislocated shoulder, are you going to force them to raise their arm up like this? No.
You have to. I need
you to. Don't do like those texts.
Yeah, but don't argue with your text when they do it.
Right.
You just hear a loud snap and they're like, oh, I feel better.
Be like, I'm gonna
Would
just
be
stand
nice
back
if it
and
was
let
that easy.
you handle this.
Like, I need you to get out of my face.
So,
Where is their shoulder?
remember, if you even suspect there's a dislocation, right, don't force the patient to do this. Just leave the arm down. Not only is it more comfortable for your patient, it also makes it easier to diagnose if there is a dislocation. Okay? So, most shoulder dislocations, right, 95% of shoulder dislocations are anterior dislocations. It pops forward rather than back. So, if you take a look here, this is not a great Y view, but we'll work with it anyway. This is the body of the scapula here, right? So where is the back of the patient? This way, that way, where's the back? Your left, your right? Which way is towards the back of the patient?
Our right.
That's right, towards the right. This is the back border of the patient's body.
So
Here's the scapula, and then here's the ribs, so you know you're going towards the front of the patient now.
So the stuff by the left marker is the crest of the spine?
So yes, you've got the crest of the spine up here. Normally you would not be able to see the crest of the spine of the scapula because it should be superimposed with your acromion. So that's why the positioning here isn't perfect. But you take a look here, what do you see?
Oh. That's right there.
So here's the arm. And where's the glenoid? Right here. So, arm, glenoid.
That's unfortunate.
Which way did the arm go? That's right, it popped to the front. Anterior dislocation.
Mr. Phung, what was that thing around the patient? That artifact?
Thing around the patient.
To the bottom right there,
Good question. What is that?
I don't know.
That's actually, yeah, would it be Velcro? Or,
It does look like Velcro. It does look like Velcro. So this potentially could be maybe like a splint or a sling or something like that.
case wrap or
All right, a
something?
few more shoulder dislocations for your viewing pleasure. Glenoid and a femoris. Not connected, right? Okay. over here, this is a view kind of like from top down. So here's our scapula, right? Here's the spine, here's our acromion, here's our glenoid, here's our humeral head. Dislocated, yeah? Anterior? Yes. It's an anterior dislocation. Notice the anterior aspect of the glenoid, posterior border of the humerus. So what can this lead to?
That's the
What can this lead to for the scapula?
of the scapula.
So this one is B. Like you're taking money to the
Bank.
right. So might have a Bankert lesion of the glenoid for the scapula, or over here you've got mountains. You've got
The hills.
Hill-Sachs Hill-Sachs defect for the posterior aspect of the humerus, right? So all of these potentially related to each other. All right, final one. Okay, last pathology.
We made it.
We made it.
What's the near method? I forgot.
It's a good question. It's been a while.
Yeah, it's been a while.
I'll have to look that up again. So, tendinitis. Okay, not too bad. Tendon, itis, inflammation of the tendon. All right, great. So this is for the shoulder, right? We've got the near method, MRI or sonography. This is just an inflamed tendon, oftentimes due to strain. Specific examples, you could also have calcific tendinitis, inflammation of the tendon, which then calcifies. Right? Because normally it's hard to see just a regular inflamed tendon. But if that tendon starts to become hard, well, now it becomes more radial opaque. Now it begins to show up. Do you see it? Where is it? Do you see that calcified tendon?
On the-
That's right. It's this line right there. That inflamed calcified tendon. All right. Very good. So that is our upper extremity pathology.
Oh.
So any questions?